Hey guys, this is Dr. Lisa Shiver, and today we're going to be looking at the concept of immunity. I want you to think about, before we get started, what all is involved in the immune system. The many parts, including things like your skin, your blood cells, your lymphatic system, your spleen. It's a complicated system that has a lot of key parts to it. To start off, we're going to look at the white blood cells and what role they play with your immune system. White blood cells are also known as leukocytes, and I'll just give you a little hint here. There is a type of leukocyte called a lymphocyte, so please be really careful not to get those confused. But leukocytes also means white blood cells, and you have several different types of white blood cells that we're going to look at. When we evaluate a patient's leukocyte or their white blood cell count level, they could be elevated due to several different reasons. It could be due to trauma, stress, infection. So just keep that in mind. Anytime you see an elevated white blood cell count, it doesn't always mean infection. It could be the day that you have an exam and you're stressed, your white count might be a little elevated. The traditional norm that we're going to use is 5,000 to 10,000 for your total white blood cell count. Now there is some variation to that depending on which facility you go to or which reference you use. You may see a white blood cell count of 11,000, but that might be considered normal at that particular facility, so keep that in mind as well. You also may have a white blood cell count that is maybe 4,000, and depending on the facility, that may be considered. So just know what the white blood cell count range is for at the facility you're working. Do note that a white blood cell count of 37,000 is definitely elevated, and a white blood cell count of 2,000 would be scary low, if you will. The patient doesn't have that immune system protection that they need, so we may have to do some other things when caring for them. With your total white blood cell count, there is something called a differential, and that's important to look at because your differential looks at each individual white blood cell and can tell you a lot about your patient. For example, you have eosinophils, you have basophils, you have monocytes, you have neutrophils, and you also have lymphocytes. Those are all types of leukocytes. Each one tells a little bit different story about the patient. If your eosinophils are elevated, that is suggesting that the patient has some kind of allergic reaction or response, or it could also be a parasitic infection. We see parasitic infections sometimes with kids. If your basophils are elevated, this is suggesting also that you could be having an allergic response. So if you're looking at your patient's total white blood cell count and it's elevated, and then you notice your patient has an elevation in their eosinophils and their basophils, then that could be suggesting your patient's having some kind of allergic reaction or allergic response. The neutrophils, that is the predominant white blood cell in the body. It's anywhere from 93 to 95% of all your white blood cells are neutrophils. So he's a major player here. He is phagocytic, meaning he will come in and clean up any debris in an area until that area is taken over by the monocytes. Monocytes are another type of white blood cell that are phagocytic. So those two work together and come in kind of like Pac-Man, if you will, and clean up the debris, the area, and they also will help repair circulation, form scar tissue, things of that nature. Something you do need to understand about the neutrophils and the monocytes. With the neutrophils, they are early to arrive, so they're going to be one of the first things that show up when there is an identified agent that needs to be handled. And so they initiate that response. They're the ones that will bring with them the heat, the redness, the swelling, the pain, and loss of function, which are all key signs of inflammation. Your monocytes will show up a little bit later and stay until everything's cleaned up. So What this means to you as the nurse, if you're looking at a patient's differential and their neutrophils are elevated, you know it's an earlier infection, versus if their monocytes are elevated, it is probably an older infection. It's not brand new. Now, something that's noteworthy about the neutrophils, there are two types of neutrophils. You have segs, which stands for segmented, and you have bands. Your segmented are your mature, fully functional neutrophils, and your bands are your immature neutrophils. So again, looking at a differential, you might see that your patient's white blood cell count is high, and then you notice that they have an elevation in their segs, and that's telling you that the mature neutrophils are out there helping fight. What's noteworthy is if you see an elevation in the segs and the bands, that is suggesting that this must be a pretty significant infection, that we've had to recruit the immature neutrophils out there to fight as well. So just some key things to look at when you're looking at your differential. With your lymphocytes, the fifth type of white blood cell, your lymphocytes are the ones that ultimately are going to make your antibodies. So your lymphocytes, there are two major types that I want you to be familiar with. You've got your B cells and your T cells. Your B cells are the ones that ultimately do the fighting, and then the end result make antibodies, or immunoglobulins is another term you'll hear. Your T cells are the ones that identify those antigens that it detects as not being part of that person. So it's the one that sees something it doesn't recognize and then initiates that response by the B cells. Your T cells play a huge role, and later on we'll talk more about how critical the T cells are, especially when they're confused or if they're absent. They can cause a lot of different issues. If your body can't tell what's good and what's bad, or it attacks good tissue, or you lose that T cell protection, it can cause a lot of different complications, which we'll get into soon. I do want you to understand the difference between local and systemic infections. If you have a local infection, you probably are going to have redness, swelling, heat, loss of function, and probably pain to an area. Those are some cardinal symptoms that occur. Now, with a local infection, I'm thinking of a small general area infection. And the redness, swelling, heat, tenderness, all of those things come about because of that neutrophil response to an area. The body's going to send more blood to an area to try to clean up what's going on. With a systemic infection, this is one that's affecting the whole system. So usually you think about something that's gotten into the blood, or maybe it was in the GU tract and now is in the blood. So with systemic, it is affecting the whole body. We often think of sepsis as well with the systemic infections. The big difference is with a systemic, you're probably going to see a systemic response including temperature, and that's important to note. You may not always have a fever with a local infection, but with a systemic infection you probably will. A blood test that you need to be familiar with is called the erythrocyte sedimentation rate. Often we refer to this as the ESR or the SED rate. This is a blood test that we do to determine if the patient has a chronic inflammatory process. The problem with this is it does not tell us where the chronic inflammation is, but it just tells us the patient has chronic inflammation. Now here's your warning. This is a test that you would never call the doctor in the middle of the night and say, hey, I've got an elevated SED rate. It is not a life or death test. It is just used to help us monitor where the patient's status is. So if I had a patient maybe with rheumatoid arthritis, and we put the patient on steroids to decrease inflammation, we could monitor their progress by monitoring the SED rate, because as we got their chronic inflammation to reduce, we would see a reduction in the SED rate as well. COPD patients will have an elevated SED rate because most of them have a chronic inflammatory process. Lupus patients would fall into this bunch as well. Again, the test is non-specific. It doesn't tell us what's inflamed. It just tells us that inflammation is present. Alright, now I want to look at a couple different types of immunity. I've got listed on this slide natural immunity at the top. Natural immunity is an immunity you just cannot get this certain thing because you're not that species. For example, swine flu. Yes, several years ago there was talk about the swine flu, but swine flu was found in swine or pigs. Now, the flu did mutate to where it could infect humans, and then we renamed it as the H1N1. So natural immunity, just because you're a human, there are certain things that you just cannot get. You cannot get feline leukemia because you're not a feline. So that's what natural immunity is all about. Active immunity, there are two types. Please keep in mind with active immunity, your immune system has to make the antibodies. Your immune system is active. Now, you may be exposed to a virus through natural active immunity where you've been sick. So if you're sick with something, you've got a healthy immune system, end result is you should make antibodies. But your immune system had to do the work. So that's why it's called active immunity. So natural active is when you're sick. For example, I've had chicken pox as a child. Hopefully I should not have any problems with that again if my immune system responded appropriately. I've made antibodies now and I'm protected. And that's why you shouldn't get true chicken pox more than once. With artificial active immunity, again, it's active, meaning the immune system has to do something, but this refers to our immunizations. With hepatitis B immunizations, we get a series of 3 injections over 6 months or so, and then end result is we make antibodies against hepatitis B. We were never sick, but our immune system actively made that protection, made those antibodies for us. So keep in mind, active immunity is when your immune system has to do something for you. With passive immunity is where you're giving antibodies to somebody. The immune system does nothing. A great example of that is natural passive immunity, where a mother passes her antibodies to a baby through breastfeeding. So passive immunity is almost like a present. You're giving somebody antibodies. Their immune system doesn't have to do anything. Please keep in mind with passive immunity, though, it is short term. Those antibodies are not permanent. Also, mom can only pass the antibodies that she has to the baby. She doesn't pass all antibodies. It's only antibodies that she has made previously. With artificial passive immunity, I've got on the slide HBIG, which stands for hepatitis B immune globulin as an example, but I've also put rabies shots out there. You may have heard cases where a patient or someone was bitten by a rabid dog, and then they had to go get a series of shots. Well, what those shots were after the fact are actually, it's passive immunity. We're giving the patient antibodies so they have instant protection. But keep in mind, with passive immunity, it's not long-lived, but it will help after an exposure. Same thing with the hepatitis B immune globulin. If somebody didn't get immunized against hepatitis B, but then they had an exposure, we could give them, after the fact, we could give them the HBIG or the hepatitis B immunoglobulin, which would protect them and give them hepatitis B antibodies after an exposure. So passive immunity is short term. Active immunity requires the immune system to actively make its own antibodies. Next, we need to look a little bit into healthcare associated infections, or HAIs. They used to be called nosocomial infections, and you may still hear some nurses refer to those, but the trend now is to call them healthcare associated infections. And just to define exactly what that is, This is where a patient comes in to a hospital, does not have this infection, but while they're here they get it, and it's more common than you think, and it's unacceptable. So healthcare associated infections, they arise in a healthcare facility. Obviously they are the leading cause of death in hospitalized patients. It's not the things the patient had when they came in that kill them, it's stuff that we give them. Transmission can be through many different forms, but the biggest thing is nurses, staff, doctors, whoever, not washing their hands. Hand hygiene is a key, such a big key to this. Also, you have to think about shared objects like blood pressure cuffs. Are we taking a blood pressure cuff from room to room to room where we're transmitting possibly germs, bacteria, viruses, whatever? So many modes of transmission in the hospital. Sites of infection, it could be many different types. You can get infections in their blood. Some patients on ventilators will acquire pneumonia while they're in the hospital. It could also be we had to put a Foley catheter in a patient, and maybe we didn't use sterile technique, and now the patient has a urinary tract infection, which they did not have when they came in. So there are many different sites of infection as well. The folks at risk are going to be anyone who is elderly, debilitated, already has chronic medical issues. So honestly, any patient in the hospital is at risk for an HAI. You may think, well, we could just give everybody antibiotics and that'll fix our problem. And unfortunately, that has happened in the past, which has led to antibiotic-resistant organisms. We have misused antibiotics due to sloppy health care, and now we have bacteria that we can't kill with antibiotics that used to kill them. So, and these are called antibiotic-resistant organisms. The first example, one of the more common antibiotic-resistant organisms, is MRSA, and that stands for methicillin-resistant Staph aureus. Sometimes you'll hear it referred to as MRSA. This is the most common healthcare associated infection. And essentially, this bacteria, which used to die when we treated the patient with penicillin, any of the penicillins, now is resistant to penicillin. So it's kind of outsmart the antibiotics. This bacteria has mutated, and now penicillin doesn't do a thing to it. It just laughs at the penicillin. We can, however, treat MRSA with vancomycin. If it's a systemic infection, we might use it IV piggyback. So with major infections, you're going to see vancomycin used, and this is long-term therapy. This patients could be on vancomycin for weeks and maybe even go home with home health and have nurses coming in to give their vancomycin doses to them at home through a VAD of some sort. The problem with vancomycin is it's not a super safe drug. Vancomycin is very hard on the kidneys, so monitoring the patient's BUN, creatinine, and also their urinary output is very important. Something else we do with vancomycin is when we're initiating treatment is we will do what's called a peak and trough. So we will draw blood tests to see the vancomycin levels at the peak and also at their trough. The peak is when the medicine should be at its highest level, and that's generally going to be 30 minutes after the conclusion of the infusion. So once the vancomycin goes in, we will draw some blood work, see what the highest level is of their vancomycin, and go from there. Now the trough should be the lowest level of the vancomycin, so that would be 30 minutes before their next dose is due. And what could happen sometimes, if their trough or their low number is actually higher than it should be, we may even delay their next dose of vanc. So as we're getting the patient adjusted on their dose and making sure it's therapeutic, not too high, not too low, we will draw peaks and troughs, and that's the nurse's responsibility to know when that needs to be done. So the peak is going to be 30 minutes after the conclusion of the dose, and the trough will be 30 minutes before the next dose is due. With vancomycin, there is another possible side effect called red man syndrome, and the patient can have some flushing while you're giving the medicine, but to fix that, you just slow the rate of infusion. You do not have to discontinue the infusion unless the patient's having respiratory issues. Vancomycin is also must be given slowly using a pump, and it's going to be over probably a couple hours, usually an hour and a half to 2 hours infusion. It's not a quick infusion. If the patient has a minor infection with MRSA, maybe they have a wound on their arm, something simple, then we may very well just put the patient on PO Bactrim or tetracycline. So the more severe infections or the systemic infections that are affecting the whole body, it's going to be vancomycin, and then if it's a minor infection, we're looking more along the line of Bactrim or tetracycline. So we use vancomycin, use vancomycin, we watch the kidneys, infuse the drug slow, monitor peaks and troughs, but what has happened with the overuse of vancomycin is now we have VRE, which is vancomycin resistant enterococci. When you're taking antibiotics, it's so important that you take the dose as prescribed, and I am guilty myself of feeling better after a couple days and thinking, oh, I don't need the other 5 days of these, I'll save them for later. But that's not how antibiotics are designed to work. When you just take a partial dose and don't take the full dose, it can cause that drug to be less effective against that bacteria, and that's also part of the reason we're seeing these germs that are the bacteria that are resistant to certain antibiotics. So misuse and then maybe overuse when not indicated are also issues too. So another reason that we have MRSA and now VRE. Luckily, we have Centercid or Zyvox that can be used to treat VRE since the vancomycin is not effective. But just imagine where we're going from here. If we continue to use Centercid and Zyvox and use them and use them and use them, you can imagine where the resistance is going to be next. So the bottom line is wash your hands, number one, but then make sure patients, when they're on antibiotics, are taking them as prescribed. But then also, are they really warranted? And unfortunately, sometimes we see antibiotics prescribed that it's really hard to justify, why are we giving this? Is it due to sloppy health care, or does the patient really need it? There are a few other drugs with documented resistance to bacteria, and I don't expect anybody to learn this list by any means, but it's kind of interesting what we're starting to see resistant bacteria to now. So the erythromycin, tetracycline, Bactrim, which I mentioned a minute ago, Rocephin and Levaquin we use a lot because they're very effective currently, but we're starting to see some resistance there. Diflucan is used for yeast infections, so now we have yeast that does not respond to the drugs we give the patient. And then there are some strains of TB, tuberculosis, that do not respond to the INH and rifampin that we traditionally use for the treatment of tuberculosis. So just wanted to show you this list so you have an idea of, gosh, this is a problem. There is one more healthcare associated infection I just want to mention called C. diff or Clostridium difficile. This one usually is related to prolonged clindamycin or Cleocin use, which is an antibiotic. So what happens is you've got good bacteria in your gut or in your intestines, and some of our antibiotics, not only do they kill the bad stuff that we don't want there, but they can also kill the good bacteria. And when that happens, that can promote the growth of C. diff. With C. diff, patients will have severe GI cramping, pain, diarrhea, could even be bloody at times. There's a foul smell with the stool as well. Frequent stools also, so not fun whatsoever. please note, as a nurse, that the alcohol-based hand rubs are not effective with C. diff. So a good rule of thumb is just to remove that hand foam that's right there by the door, which will remind people, hey, we really need to wash with soap and water. Treatment for the C. diff, we can treat it with our vancomycin again. So remember, vancomycin, it's a powerful antibiotic, and there are a lot of things you have to monitor. We can also use Flagyl. Flagyl isn't always user-friendly either. You cannot drink alcohol while taking Flagyl, or it will cause profuse, projectile, severe vomiting. So that's a no-no. So as a nurse, just keep in mind, if you have a patient with C. diff, you've got to wash your hands with soap and water. The foam is not going to manage that. Also, your patient will be put on enteric contact precautions, and that means that we have to wash with soap and water. So you'll see that signage on the door. So what can I do as the nurse? Well, it really depends on what your patient has. If a patient has MRSA or VRE, well, then you will put the patient on contact precautions. If your patient has C. diff, they'll be on enteric contact precautions, meaning washing with soap and water is required. Please review what standard precautions are involved, and also please review what droplet precautions are, airborne precautions, contact, and also protective. With the protective precautions, this is going to be where the patient, maybe their total white blood cell count is really low. They don't have those natural defenses to protect them. So we would wear the mask into the room, because something that wouldn't make me or you sick because we have a healthy immune system could make that patient very sick. So putting this homework on you, please make sure you are familiar with the CDC isolation guideline table. I think that one was released in 2007. It's about time for an update on that. But check that out, and also make sure you know the sequence for putting on your protective equipment. Does the gown go first? Do the gloves go first? Do the goggles go first? And then be sure you know how to remove those, remove that equipment as well.